All right, we're going to talk about some pulmonary hypertension under the concept of oxygenation. So when we talk about, and I know Ms. Coffey's been discussing ventilator and oxygenation as well, and so will Ms. Murdoch, but when we talk about oxygenation, let's go back quickly through A&P and think about our normal lungs. We have two normal lungs. On the right, we have 3 lobes. On the left, we have 2 lobes split between a heart. So in chapter 23, starting on page 613, starts pulmonary hypertension. And when we look at these, I know I just skipped around flight of ideas. When we look at this slide, we're looking at the bronchioles. We have a right and a left bronchus, and then we go down all the way to the alveoli. The alveoli is the most important part of this because this is where oxygenation is going to happen. So in this picture, we will see that over here on the lower right corner looking at the screen, we see the alveoli, and we see the blood, the capillaries. There is the point where carbon dioxide and oxygen is exchanged. Now that's a big part of the respiratory system, pulmonary system, and the cardiovascular system. The lungs have a specific job, and that is oxygenation. So remember last week when we did the trace the blood through the heart, pulmonary arteries bring deoxygenated blood from the heart going to the lungs. And remember, pulmonary veins is what brings the oxygenated blood back to the left atrium. Right? Pulmonary hypertension. Pulmonary hypertension, defined by your MedSurg book, says it is characterized by elevated pulmonary artery pressure and secondary to right ventricular failure. So in the picture on the left, looking at the screen, the normal heart, we see the biggest thing I want you to see here is the right ventricle. So in the right ventricle going to the lungs, we have that pulmonary artery taking that deoxygenated blood over to the lungs to pick up its oxygen. It has a job. So on the right side, because of pulmonary hypertension, you see in the window where the pulmonary vasculature is very narrowed. And we're going to go over the reasons why that happens. But this is the reason pulmonary hypertension causes such problems in folks. So pulmonary hypertension can be suspected in clients that have dyspnea on exertion without other clinical manifestations. So nursing is going to have to do a very thorough history and physical when they talk to these folks, either in the office or when you get an admission or when you talk to your clients that you're taking care of. Because the body is independent of its own systemic hypertension, it's usually not evident with pulmonary hypertension, but you will see pulmonary hypertension later in progression of stages. So with exertion, that means walking up steps, walking for some folks for any short distance. And the body requires a higher demand for oxygen. So what happens, think in your noggins, put your thinking caps on, what happens to the body when the vasculature is deprived of oxygen? Vascular becomes narrowed. Therefore, the pulmonary arteries don't work the way that they should. They don't carry the blood the way they should because they become narrowed and then the areas become hypertensive. Because the pulmonary hypertension, the vasculature has been impaired, has been damaged, or some sort of obstruction. And this raises the pulmonary artery pressure and the resistance it takes to get the blood to and fro. This also increases the workload of the right ventricle because it is the one pumping it to that area and affects the function of the right ventricle, thus becoming enlarged. Hypertrophic is the key word. So eventually the myocardium, Ms. Doig taught you about, the layer of the heart, cannot keep up. So the right ventricle becomes hypertrophied, enlarged, and dilated. So the World Health Organization classifies pulmonary hypertension. This is in your book on page 613, chart number 2311, chapter 23. Why do we classify pulmonary hypertension? We classify it so we know how to treat it. So to treat pulmonary hypertension, say for instance in COPD, the same as somebody with, we wouldn't treat them the same as we would treat someone with pulmonary thromboembolism. So group 1, I'm going to read it to you right off the slide. Your notes are right here. Group 1, pulmonary artery hypertension. So when the pulmonary artery is hypertensive, it causes sporadic idiopathic pulmonary artery hypertension. These folks have inherited idiopathic pulmonary hypertension. They are grouped because they are drug and toxic induced. And pulmonary artery hypertension due to diseases such as connective tissue disorders and HIV infections, portal hypertension from the liver, and congenital heart diseases. So group 1 are all of these things combined together, classified. Group 2 classification is when pulmonary hypertension is due to left heart disease. So you have your systolic dysfunction, your diastolic dysfunction, and we talked about in Unit 2, your valvular heart diseases. Group 3 is the big one, and the one that I want you to pay the most attention to. Pulmonary hypertension is due to chronic lung diseases and or hypoxemia. Chronic obstructive pulmonary disease. These folks' vasculature is very constricted. Their airway is constricted. Everything is constricted, obstructed. Interstitial lung diseases, mixed restrictive and obstructive lung disease, and sleep disordered breathing. Sleep apnea, that's what that means. So you take your patient that has obstructive sleep apnea, they actually stop breathing and are apneic for any period of time, and they end up in this group 3 category. Group 4 category is the chronic thromboembolictic pulmonary hypertension. You see the abbreviation, and this is due to thromboemboli, occlusions of the proximal and distal pulmonary vasculature. These folks have pulmonary emboli frequently. Group 5 is a varied group. These conditions result from multiple pathophysiological issues. Hematological disorders, systemic disorders such as sarcoidosis, hardening of a particular organ, or metabolic disorders. You'll discuss them with Ms. Kofke in acidosis with blood gases and alkalosis. So these are your World Health Organization classifications of pulmonary hypertension. Biggest one I want you to concern yourself with is the group 3, chronic lung diseases and or hypoxemia. What does our patient look like that's clinical manifestations with pulmonary hypertension? Signs and symptoms are listed right here for you. Dyspnea. Know this. Dyspnea is the main symptom of pulmonary hypertension. It occurs first with exertion and then eventually when these folks are resting. Remember we talked about previously the number of pillows it takes to raise the body up to be able to rest. So going clockwise, lightheadedness or loss of consciousness. Why do you think pulmonary hypertensive folks would have lightheadedness, syncope? Because, pausing so you can think out loud as you're listening, oxygenated blood is not getting through the carotid arteries to the brain. The brain needs oxygen, right? So these pulmonary hypertensive folks have a dry cough. They have abdominal bloating, rapid weight gain, swollen ankles and legs. These kind of remind you of right-sided heart failure. You said it, right there they are. They're tired, they're sleepy, they can't stay awake. They do have fatigue and weakness. They don't have enough oxygen to keep them going. They are short of breath, fluttered chest sensation. Sometimes these folks have arrhythmias. Chest pain, it is described as substernal, but you also have folks with just chest pain because my vessels and my arteries are not open for the blood supply to get where it needs to get. And you will note that these folks have bluish lips or bluish colored skin. We used to call them the blue bloaters that would sit on the side of the bed, have to have their arms up on a bedside table and leaned over so they could pull enough air into their lungs to be able to breathe. So here, pulmonary catheter, on the left side of the picture, we see the heart, we're doing a heart cath. So diagnostically, we talked about that extensive H&P. What risk factors does your patient have? What signs and symptoms do they have? These folks need to be monitored very closely because these are the folks that have frequent admissions to the hospital. Dyspnea, shortness of breath, substernal chest pain, weak, fatigued, syncope, occasional hemoptysis, occasionally with their cough, signs and symptoms of right-sided heart failure. Can't express to you enough that you need to know those. They are in your book. As we said earlier, on their H&P, pulmonary hypertension occurs first on exertion, but eventually, when these folks are sitting and resting, they're still short of breath. Chest x-rays can help us rule out causes like infiltrates, atelectasis, or pleural effusions. So we can see the size of the heart, we can see the size of the right ventricle, and we can see what's going on in the lungs. Pulmonary function test, PFT, may be normal or slightly decreased in lung capacity and compliance, so they could have a decreased PaO2 on their blood gas and be hypoxic. EKGs can show us right ventricular hypertrophies because that right ventricular is having to work really hard, and we can see tall peaked P waves in the inferior leads on the 12 lead, that's lead 2, 3, and AVF. Don't expect you to know every single time you look at a 12 lead. Remember we talked about when we look at a 12 lead, we need to be able to note ST elevation. Echocardiograms can estimate pulmonary artery systolic pressures and right ventricular size, thickness, and function of the right ventricle, and also right atrial size, left ventricular and diastole function, and the valve function. So echoes tell us quite a bit. VQ scans You see that V and you see the Q. Q is the ventilation perfusion. Are we able to ventilate our lungs and get the oxygen where it needs to be? And are we able to perfuse? Is the heart able to pump it, to perfuse it? Now, the picture of the pulmonary catheter is what it looks like when they go in and they do a right heart cath, necessary to confirm the diagnosis of pulmonary hypertension and accurately assess the hemodynamic abnormalities of the valves, the heart, the chambers, so on. So when we do the right heart cath and diagnose pulmonary hypertension, it is confirmed with a PA pressure, that pulmonary artery pressure, greater than 25 millimeters of mercury. Medical management for these folks in pulmonary hypertension, we're going to treat the underlying condition, and we're also going to have pharmacological therapy. So oxygen, what do you think about when you send a person home with oxygen? Hopefully what you thought is the patient going home with oxygen? Do they smoke? Nursing has to teach them you cannot light a match or light your cigarette around oxygen. Remember that the primary goal for pulmonary hypertension is to treat the underlying condition if it can be identified through the slide that we just looked at. All pulmonary hypertensive clients will be considered for diuretics, oxygen, exercise tolerance, digoxin, and what will the digoxin do for the heart? So these medications, the diuretics, the digoxin, the calcium channel blockers, you have already learned about. You should know about them. So you have to take into consideration when we talk about them, what is a diuretic? What is the diuretic going to do for this client? And what are side effects of diuretics? What labs might I need to watch for diuretics? So digoxin, what is it going to do for the heart? Help increase that contractility. And what are some things that nursing needs to watch for digoxin? Also the same thing as lanoxin. So I need to watch my heart rate. Is it too low? I need to watch the therapeutic level of this lab. These are the things that you should already know. And with these medications, along comes other medication. Prostanoids. Prostanoids help relax smooth muscle. So if we're able to relax the muscles, then that will help. But we also need other medications following the two below are going to help us with our vasculature. Prostanoids have a short half-life. Flolan, given continuously IV on a 2 to 3-minute half-life. Remdilin can be given IV or sub-Q. It's documented to be a painful injection if given sub-Q. REMODULIN, Remdilin, and Ventavus is inhaled 5 up to 9 times per day. Got to carry that one in your pocket. So then we talk about the endothelium antagonist. These receptor antagonists vasodilate vasculature. Tracleer, Lataris are around $10,000 to $13,000 a month. Tracleer is TRACLEER, and Lataris, LETAIRIS. Those are endothelium antagonists, and they are very expensive. So yes, there are help programs for these medications. And what happens when the patient runs out? too soon, too quick, because you know some folks take their medication not as prescribed. So nursing needs to teach the client about medication compliance. Phosphodiesterase 5 inhibitors. These are cheaper medications and can be effective for helping pulmonary hypertensive folks, but sometimes they don't always work for everyone. These medications work by promoting pulmonary vasodilation. These medications are your sildenafil, Viagra, Cialis, and Levitra. So these medications that you have heard of before treat erectile dysfunction, but they are very helpful for your pulmonary hypertensive patient that needs pulmonary vasodilation. So these medications, what do you think about and what education do you give your client when you give them Viagra and they have a nitroglycerin bottle in their pocket? No nitrates for chest pain, right? That is correct. Or if you do, you better be careful using them. Surgical management of pulmonary hypertension. The biggie here is lung transplant. And remember we talked about back in cardiomyopathies, we talked about heart transplant. Not everyone gets a set of lungs or a lung during their time that they're on the transplant list. They may be an option for a select group of clients who don't respond to therapies that we just talked about. And then we also have the Atrial Sep Septuostomy, may be considered for severe diseases of pulmonary hypertension, which this procedure shunts blood from the right side of the heart to the left, decreasing the strain on the right side of the heart and maintaining left ventricular output. But the not so good thing about that procedure is you're mixing oxygenated and unoxygenated blood. Not very many options. We have medications, we have lung transplant and atrial septostomy. So nursing for these pulmonary hypertensive folks is prevention. What can we teach them to keep them out of the hospital and decrease their signs and symptoms? So the major nursing goal is to identify patients at high risk for pulmonary hypertension and to start treatment early. I'll repeat that. The major nursing goal for pulmonary hypertensive patients is to identify patients at high risk, your COPD patients, for pulmonary hypertension to start early treatment. So those folks at high risk, COPD, PEs, constant frequent pulmonary embolies. Then you have your congenital heart disease patients, and you have your mitral valve diseased patients. So nursing management, prevention of symptoms, education on meds, oxygen at home, and med compliance, and being honest, truthful, and mentioning to their provider which meds work for them and which do not. So support for these pulmonary hypertensive folks is emotional and psychosocial aspects of the disease. It's going to be hard for them to get up and go and do the things that normally they should be able to do. So there are support groups, and there is also what's called pulmonary rehab. You'll hear it called pulmonary rehab or cardiopulmonary rehab. Big thing nowadays. Let's go to the next topic. I've heard this pronounced many different ways, but I'm going to say it as cor pulmonale, heart and lungs. The core being the heart and the pulmonale being the lungs. How do these two things work so well together? Can't do without the other. On page 614 in your book is a very short blurb about cor pulmonale, and I'm going to take you just a little farther into cor pulmonale because we end up talking about right ventricular heart failure. Cor pulmonale is a condition that results from pulmonary hypertension, which causes the right side of the heart to enlarge because of the increased workload required to pump blood against such high resistance through the pulmonary vasculature. So essentially what that means is you have all this blood coming back to the heart on the right side. We get right atrium, we go across the tricuspid valve into the right ventricle. That right ventricle has to squeeze the blood out to the lungs through the pulmonary artery. Now, this pulmonary artery is already tightened because of the lung disease going on. So then this is where we get into trouble with right-sided heart failure. Chapter 29 in your Med-Surg book, I don't want to say the word deals, but I did. So it talks about it in detail. Remember, with your heart, you move backwards from the problem area. So the lungs being the problem area, moving backwards to the heart and the right ventricle pulmonary artery. So now it's the right side of the heart, right ventricle. And we have to think about where that blood is coming from, the body, the venous system. Cor pulmonale or right-sided heart failure is an enlargement of the right ventricle due to high blood pressures in the lungs, usually caused by chronic lung disease. So we see in the picture on the left, looking at the screen, we see a dilation and a stretching of this right ventricle. We see some hypertrophy here, the overgrowth of the ventricle muscle itself. So up here, this blue artery goes, pulmonary artery goes to the lungs. And in the lungs, because of the disease process, makes this pulmonary artery constrict, hence causing right ventricular failure. So causes of cor pulmonale is high blood pressure in the arteries of the lungs, pulmonary hypertension, and because of that, cor pulmonale is defined as or right-sided heart failure. In patients that have pulmonary hypertension, changes in the small blood vessels, the lungs, can lead to increased blood pressure in the right side of the heart. We just said that over and over and over. This makes it harder for the heart to pump blood to the lungs. If this high pressure continues, it puts a strain on the right side of the heart. The strain can cause cor pulmonale. Lung conditions we've talked about, COPD, it's kind of similar to your pulmonary hypertension, but we're ending up with right-sided failure, which is also called cor pulmonale. Autoimmune diseases, the scleroderma, the chronic obstructive pulmonary disease, COPD, chronic blood clots in the lungs, cystic fibrosis, severe bronchiolithiasis, and scarring of the lung tissue. And one of the biggies, chronic obstructive sleep apnea. I don't know if you guys, I'm sure you have at some point, and some of you may know from your own family members or patients that you've taken care of. Obstructive sleep apnea is very, very dangerous. If not taken care of, it can cause a lot of signs and symptoms, and sometimes these folks can go to sleep and never wake up. Here's a cartoon of cor pulmonale. I like this picture because why? It describes right-sided heart failure. Cor pulmonale is known as right-sided heart failure. So let's talk about these symptoms. Moving clockwise It may be secondary to chronic pulmonary problems, pulmonary hypertension. You may see distended neck veins, JVD. You may see or hear of anorexia because you have GI distress, you have liver enlargement, you have ascites going on, you have weight gain, you have dependent edema in your lower extremities. So in this picture, they have enlarged liver and spleen because this area of the abdomen gets enlarged. Then we have increased peripheral venous pressure and fatigue. These folks do not have the air to move where it needs to go. So when you are talking to your clients that you are taking care of with pulmonary hypertension, their physical history and physical is very, very important. So because of the venous dependent edema in the lower extremities makes the liver enlarge, hepatomegaly, and folks will complain of right upper quadrant tenderness. All right, so we discussed all the symptoms. Cor pulmonale, same thing as right-sided heart failure, caused by pulmonary hypertension. Medical management of cor pulmonale, goal of treatment is to control the symptoms. We just said that for pulmonary hypertension. It's the same for cor pulmonale. Thorough history and physical. Talk about the symptoms that your client may be having. Let them tell you what's going on. Labs that we're going to look at are our chemistry profiles to make sure that our kidneys are functioning, our liver, and our electrolytes, because remember we gave them diuretics with pulmonary hypertension. We need to make sure their potassium, sodium, and chloride are within normal limits. So when we send these folks home, we said earlier on oxygen, nursing has to educate. We have diagnostics, which are your echo, your EKG, and your chest x-ray. Very, very similar to pulmonary hypertension treatments, but these are cor pulmonale. So BNP, B as in boy, N as in Nancy, P as in Paul, is the brain natriuretic peptide. It is a key indicator of heart failure. This is a lab. So the hormone BNP is released. High levels are a sign of high cardiac filling pressures and heart failure. So we need to watch those lab levels. BNP. CT of the chest can tell us more about what's going on in the lungs and the heart. ABGs can tell us if they're hypoxic or not. Pulmonary function test, right heart cath again, and ventilation perfusion scans, and then testing folks for autoimmune lung diseases. What's nursing going to do? We're going to assess symptoms. Are you dyspneic on exertion or when you're sitting down and resting? We're going to educate them on oxygen, medications, med compliance, diet. What kind of diet do you think we need to educate these folks on? Low sodium, I hope you said. We're going to teach them how to weigh daily. When do we weigh? First thing in the morning in your birthday suit. We're going to teach them exercise may not be the good thing for you to do because of intolerance to exercise and your ability to move oxygen where it needs to go. So we may need to talk to them about some things they can sit and do and not have to get up and do exertional exercise. No exertional exercise. So we're going to talk to them about smoking cessation. When you go send your folks, when you send your clients to pulmonary rehab, they'll go through a program if they smoke for smoking cessation. Sleep disturbances. Do you have sleep apnea? I need to know that. and reducing fatigue, managing fluid volume, and here again, I'm going to say this word again, medication compliance. Now, Ms. McCarg has said to you before, if you have any questions regarding lecture, please reach out to me, email, you can call the office, better to email me. I will help you my best to try to figure out and help you understand pulmonary hypertension, right-sided heart failure, same thing as core pulmonale. Know your signs and symptoms of right-sided heart failure. Know where the blood is coming from and where the blood is going to and why it can't get to where it needs to go. Know your medications, because anything that you've ever covered before can be covered in 213 because it's complex issues. All right, guys, that's pulmonary hypertension, core pulmonale in a nutshell. Have a wonderful evening, and I will see you soon.